Hey everyone, it's Jeremy Thiel. Back here for our 1 o'clock presentation. For those of you who don't know me, I'm the Senior Manager of Marketing Ideas and Education at DriverCheck, and I've been your moderator for the week. So again, just a friendly reminder, everyone's on mute except for our speakers. But if you want to submit any questions, just look at the bottom of your screen on the Zoom window and you'll see the Q&A icon. And if we don't get to any of your questions today, we'll follow up next week with some emails. If you have any technical difficulties, majority of those issues can be addressed by looking, there's an up arrow or a chevron key icon in the bottom left-hand corner of your screen. From there, you'll be able to select such things as proper microphone, adjust your volume, etc. So we are recording all the sessions. We'll make them available next week for download. And just again, set the context about the Fitness for Duty Summit of this year. The theme is Inspire Change. And so what we're hoping to do is inspire change and invoke discussions that are going to lead to a healthier and safer world. The objective is to provide attendees with knowledge, insight, action items to address workplace challenges that are going to promote a healthy and safe work environment for their staff and the general public, from both a physical and mental perspective. Now I'm going to pass it over to Jonathan, who will introduce our next speaker. Jonathan?
Thanks very much, Jeremy. Hello, everyone. I'm Jonathan Davids. I'm the Corporate Medical Director for DriverCheck. I'm pleased and privileged to be able to introduce some of our DriverCheck's clinical team over the course of this week's Fitness for Duty Summit. We have an amazing group of clinicians from OC Health nurses, OC-Med physicians, addiction medicine physicians, and medical review officers. Now, Dr. Melissa Snider Adler is both addiction medicine physician and medical review officer. In fact, she's DriverCheck's chief medical review officer. Some of you might have heard one of Melissa's many talks over the past few years on cannabis and impairments, workplace substance abuse, or addiction prevention and treatment. She's qualified as an expert witness in the Ontario Court of Justice. Is often called on to provide expert testimony for labor arbitrations and other court cases. Melissa also consults with many of DriverCheck's clients to develop and update their alcohol and drug testing programs. Now with COVID, as many of us have done, Melissa has also shifted some of her focus on helping DriverCheck's clients with respect to COVID testing. This is something that is a bit of a moving target and it changes frequently. So it takes time to keep up with the changes and to be informed. What we know today will often change tomorrow. So I think we're pretty lucky today because Melissa's presenting the most up-to-date information on what's available in the COVID testing arena, what testing can and cannot tell us, and she'll also discuss some current best practices for utilizing COVID testing in the workplace. So I know we're all looking forward to this talk. So with that, I'll pass it over to you, Melissa. Take it away.
Great, thank you. Let me just share my screen and then we will be good to go. Sorry. There we go. Okay, first of all, thank you, Jonathan, for the introduction, and thank you, Jeremy. And I do want to thank DriverCheck for not just canceling the Fitness for Duty Summit, but trying to go with what the times are these days and being able to provide all of our clients and anybody interested really all of the latest information in dealing with what we are all dealing with now. So with that said, we're going to go through a little bit about COVID testing, really what we're seeing right now, what's available in Canada, what can become available or will become available, and then how do we put that all together in the workplace. So that's really what we're going to be focusing on. I just want to remind everybody exactly what Jonathan just said. This is a dynamic situation, and I gave this talk or something similar a couple weeks ago, and what I'm saying today is different. So things change very quickly in this space. And so if you are looking at this later, even in a week from now, or looking at the slides, I just want to remind everybody that if you want the most up-to-date information, reach out to us. So just as a very, very quick start here, SARS-CoV-2 is the virus. The virus leads to the coronavirus disease 2019 or COVID-19. it is easier probably that I refer to everything as COVID-19. And so I'm just going to use that, even though we know really the disease is COVID-19 and the virus is the virus, but it makes it easier to speak. So I'm going to start off just letting you know that. Let's just go through where we're at right now. I'm not going to harp on this for very long, but I think it's important, and you'll understand the importance in a moment when it comes to testing, that we know where we're at right now, because how the tests work and how good they are also dependent on where we're at in the COVID world, like what are the percentage of the population has it or had it, etc. So, this is as of yesterday, I believe. Yes, yesterday, we are almost at 38 million people and over 1 million deaths worldwide. When we're looking at Canada, again, it's over 182,000 cases, with the vast majority being in Ontario and Quebec. That's not to say that the rest of the country is not affected. We all are affected, but that's where the majority of cases are seen right now. When we break down the numbers, and it is important to look at the numbers when we get them day to day. So, we see these alarming numbers that we get, these just raw numbers. So, in Ontario, whether it's 700 or 800 new cases a day or 900 or whatever it may be, we need to take that into the context of the number of people that are being tested. And so if you look at, for example, if you look at our deaths, we're at 5.3%, which is higher than the worldwide average, which is 2.85%. I'm not going to get into some of the factors that have led to that, but I just wanted to point that out. But when I'm talking about positive tests, what I was referring to is the percent positive tests. Now, I'm going to just skip to the next slide for a moment. Sorry, one second. And this is an interesting chart where we look from the very beginning and we look at the number of tests we did and the percent positive. You can see it went well above 12%, and it was sort of hovering anywhere between 6 and 10% in the height of everything in the spring. And then we dropped down. This is just on average. It's a weekly average across Canada. And it's starting to creep back up again. Now, what does all of that mean? So when we look at the numbers, we really also have to consider how many tests are being done. We know that we're doing more testing now than we were in the spring. For various reasons. And the people in the spring who were tested were mostly the ones who are very sick. So of course, we're going to have a higher positivity rate. But what they do say is that the positivity rate helps to guide where we're at in the disease, how we're doing with testing, and the population really that's affected. And when we look at there we go, Canada and the US, just as a comparison, because I always like to compare our neighbors, you can see that the US is significantly higher from a positivity rate. Not really surprising. We know that they are being affected to a much greater degree than we are, again, for various factors and reasons that I'm not going to get into politically. So let's turn to the workplace with all of that as a background. When we're talking about employees with COVID, we are talking about symptomatic employees. And I will say that I'm not going to be talking so much about symptomatic employees. Those ones are pretty easy to deal with. You have symptoms, you quarantine, you get tested, we can deal with that. The more concerning one are the pre-symptomatic and asymptomatic. So what is the difference? Pre-symptomatic are those that have the virus, are shedding the virus so they can spread it to other people, but it happens in those couple days before they start to get symptoms. So we know that you're contagious for a couple days before your symptoms start. Asymptomatic is the person who is shedding virus all along, but never develops symptoms or never develops severe symptoms that they attribute to COVID-19. And we call those asymptomatic. They can still spread the virus. Now, when we put this, just so that you can see here, just to make it a little bit more clear, day 0 being when you were exposed to the virus. So it takes a couple days for the virus to build up in our system. That's that latency period. And that's about 2 days. Now, again, this is average. So this is not for everybody, and things may be more prolonged. Like it may take longer until you get to symptoms, which we know. The average person will start to have symptoms on day 5 after being exposed. We know, though, that can go up to day 14. That's why we have that 14-day quarantine, isolation, et cetera, after travel and exposure, symptoms, etc. However, by day 5, that's when most people become symptomatic. So if you look here, you can see that before you become symptomatic on day 5, on day 3 and day 4, you are pre-symptomatic, shedding virus, spreading it to other people without knowing that you are about to get sick and have symptoms. And so, those people, we want to make sure that we're catching them. And when it comes to testing, the real part of that is let's pick up those pre-symptomatic before they even know that they're going to develop symptoms while they're spreading the virus so that it doesn't spread to the rest of the workers. And obviously asymptomatic people, they have that pre-symptomatic phase as well, but they just never develop symptoms. They continue to be asymptomatic. So what I really want to emphasize here is there is no perfect test for every situation and every person. So there is not one test for each person, for each time frame, or for each place, situation, location, etc. What I mean by this is that it is really important to know all of the details of what is happening in your part of the world. So knowing what the prevalence rates of COVID-19 in your area surrounding your workplaces is really important. If you don't have a very high prevalence or you have a high prevalence, the way we interpret tests may be different. The types of tests we choose may be different. It's also important to know the timing. Where are you at? Is this person with symptoms? Is this a person with no symptoms? Have they had symptoms for 5 or 7 days? Have they just developed symptoms today? All of that helps to guide us. So we want to sort of take all of this into consideration when we're choosing the right test for that right time, for the right person and the right location. Again, when we say location, we're also talking about things like doing testing right at the workplace, having a result available right away, whether it's sent to a lab or not, how far away you are. The truth is if you do a test and send it to the lab, and the turnaround time is going to be a week or 10 days, that may not be very useful for you. So having all of that is really important. So why even talk about testing? We know that for the most part as Canadians, and certainly in workplaces, we have had to make tremendous changes to how we live our lives, what work looks like, what we do in order to get to work, and how we actually work, whether it's masks, temperature taking, screening beforehand, working from home, distancing, etc. But COVID testing is not in place of all of this. So what we want to do is put it all together, and especially for different situations, even like high-risk workplaces. So we know that there are certain workplaces that just by the type of workplace, the type of environment, etc., may be higher risk from a spread perspective. Now, it also may be a workplace where we know that if it's going to spread and you're going to lose a bunch of people to being in quarantine or isolation, it's going to have a tremendous impact on, whether it's productive, like how productive you are, et cetera. So it's, or the workplace and just how it's working. And so all of these things need to be taken into consideration. Obviously, things like ventilation at work, whether you're indoors or outdoors, what the ventilation is like, some of the things that Jonathan talked about yesterday, if you had the privilege of listening to his talk, which was wonderful. But these are the types of things that we really need to add in a little bit more than all the things that we're able to do in the workplace. So, whether it's a factory or mines or, somewhere offshore, et cetera, this is part of one of the strategies. So we still need to continue with cleaning. We still need to continue as much as possible with separation or physically distancing of, they say 2 meters. Sometimes that's not possible in some of these workplaces, but where it is, it's important. Certainly face coverings or full PPE if that's the case that needs to be. So this is all part and parcel of the whole thing. There are some people, our neighbors in the South, I won't again get into politics here, but some presidents may feel that testing every day means that you don't need to do all the other strategies that we need to, but that is not the case. You could be testing every single day, and we still need to be taking care of all of the other things: cleaning, face mask, hand washing, and distancing. All right, here we go. This is as of last night and this morning. So this may change, but I did check it this morning to be sure. We now have 41 approved tests by Health Canada. 28 of them are nucleic acid testing, which is PCR testing. And out of those, some of them are point of care tests and others are classified as lab tests. We have right now 3 point of care tests that can be used as point of care tests. There is one more, which is now only for research purposes. So I'm not counting that one, but that's the extra one there. 37 have been authorized for lab-based testing. Some of those are actually portable tests and can be used on site, but need a bit more factors in place with respect to who's allowed to do the testing. There has to be oversight by a physician. So there's other things that have to be taken into consideration, but they are available as well. Serological testing is antibody testing. In the world, there is the availability of point of care antibody testing and lab-based antibody testing. In Canada, the only ones that are approved are lab-based testing. This is a blood test to look for the antibodies. We'll talk a little bit more about that, but there are 11 of them that are approved right now. Antigen testing is the newest member of the testing family to be authorized in Canada. There are now 2 point of care tests for antigen testing, and we're going to spend some time talking about that. But before we go through everything, I want to do a bit of a reminder of sensitivity and specificity, which for some of you, you already know this because you're dealing with it when you're dealing with testing, but it is just important to get an idea of what we're talking about here when we say about the sensitivity and specificity. So essentially, the sensitivity is the ability to rule out the disease if the disease is negative, meaning if you get a negative test, how sure are you that that's a real negative and not a false negative? And when it comes to diagnosing COVID-19, we really do care about sensitivity because we want people who have the disease to be picked up and know that they're positive if you're going to be doing a test. So we're going to differentiate a little bit between the sensitivity of one test and the sensitivity of a testing regime or protocol. And I'll explain that afterward, but just keep in mind that sometimes when we are doing a protocol with multiple tests throughout the week, the sensitivity altogether of doing multiple tests is different than just doing one test alone. Next is specificity. So specificity is the ability to rule in the disease if the disease is positive, meaning if you get a positive test, how do we know or how certain are we that this is really due to SARS-CoV-2 or due to something else? That's a specificity. And so if we are doing antibody testing, for example, where we want to know whether somebody was exposed or had COVID-19, they've developed antibodies, we kind of want to know that when we have a positive test for that, that it is a true positive. And we'll talk a bit more about antibody testing because it's not a lot of use right now, but I'm just using this as an example. I wouldn't want somebody to have a negative test for this. A false positive test for this, where they say it's positive, but it's really not, because then the person thinks, oh, I had it, I'm protected, and I'm good. And just as, you know, a general, how we all are, we may take less cautions when it comes to spread of the disease. So these are really important to understand for each test. I mean, there's other parts of the testing that we need to look at as well, but we will be talking a little bit about that. So I wanted to just go over that. So nucleic acid testing. This is what we consider now to be the gold standard of testing for diagnosis of COVID-19. It's a PCR test. As I said before, there are 3 point of care ones in Canada that can be used. And, you know, we will talk a little about point of care versus lab-based, but the truth is the ones that are approved in Canada, the point of care ones, are really no different from a sensitivity, specificity, positive predictive value, negative predictive value, accuracy, everything that we talk about. There's not that much difference between them and the lab. So when it comes to using one or the other, it really is just about things like cost in general. You know, how many tests you can do an hour, whether this is something that you want the result of right away. But when it comes to PCR testing as a whole, whether it's lab or POCT, they are the gold standard, but that does not mean they're 100% sensitive and 100% specific. They're great. They are the best that we probably have right now in certain circumstances, but we do see false negatives. So why is that? We see false negatives if the test was done too early and the virus, like the amount of virus that's there, does not exceed the amount that we need in order to really pick it up. So that's one. Two is the type of swab that we do. And we'll talk a little bit about specimens in a moment, but depending on the type of swab that you do, you just may not capture as much of the virus as we need in order to test positive on one of these tests. So as I was saying before, with respect to the point of care tests, you buy a little machine. It's like a little laboratory machine, but it's portable. And that's what the test is used to run. And then depending on the test, there's a whole number of steps that need to occur beforehand to prepare the sample to be able to put into the machine that they're using to do the testing. So it does take time from a setup perspective. You do need training in order to do it, and different ones need different levels of training and levels of expertise in running them. But certainly, it's not something that you just, it's not like a pregnancy test where you just, pee on a stick and you get a result and anybody can do it. It's much more, it's a much more detailed process that needs to be followed exactly. But again, accuracy, similar to lab, I have no concerns with respect to that, but they are expensive, the machines, and then you have the per test cost. But you can see that it can take a few hours to run, and depending on the machine, maybe you're running 7 tests at a time or 9 tests at a time. There likely will be the ability to run more as time goes by and to increase the number that we are being able to test. So when it comes to PCR testing, really, it ranges from about 70 to, from a sensitivity perspective, to 95%. And, that may be, as I said, because of the swabs and the timing, et cetera. So I'm not going to spend a long time talking about serological testing, but antibody testing, but I do want to bring it up. To be honest, at the very beginning in March, when we were really just starting to dive into testing and what is out there, I personally thought that serological testing was going to be the be all and end all. And my reasoning was that if we knew that a person had COVID-19 and had the antibodies, then we may be more prepared to put them in different situations where we were not able to have great ventilation or, masks, PPE, all of that. What we know now is that's not really the case. And the reason for that is this. We know that immunity does not last forever. So that we know now. We just don't know exactly how long it lasts. So, does it last 3 months? Does it last 6 months? We don't have a lot of information about that. We're starting to gather it, but there's a lot of question about that. And then the other question comes up as to whether or not those antibodies are going to protect against all of the different strains that may be out there. There was a report of an individual who had COVID-19, had one strain, and then got sick months later with another strain, and so was reinfected basically with a different strain and was not protected. So we don't have all the answers as to how sick he got. Maybe he wasn't as sick as he was the first time. There's a lot that we don't know. I would say right now, from a workplace perspective, antibody testing is not likely to provide us with any more information, being able to get people back to work or keeping them at work or preventing an outbreak or a spread, which is really what our goal is. But I did want to bring all of that up. All right, antigen testing and CRISPR, 2 things that we're going to talk about. Antigen testing, as I said, is the new kid on the block here. It is an immunoassay test, so it's in theory a screening test. It is a nasal swab collection still, so some of them are only nasopharyngeal, others could be nasopharyngeal, anterior nares, so just in the nose, a little bit deeper, oropharyngeal, basically throat swab. So depending on which one, they are validated for different types of swabs. So that's the first thing that you want to be aware of when we're looking at what kind of antigen test you should be using. The nice thing about this is that they tell you positive or negative, so it's qualitative. So is PCR, qualitative. It looks for the virus itself. It looks for proteins or antigens that are on the virus. So it's detecting whether you have the virus. The results are very quick. Most of them are 15 minutes. I did say 15 to 30, but all of the ones that we have in Canada now approved and that I've been looking into are about 15 minutes. They are much less expensive than PCR testing, significantly. Their sensitivity now, they vary. So when they're talking about sensitivity, they're comparing it to PCR testing. So already PCR testing we know is not 100%, okay? But some of them will say we have 98% sensitivity or 99% sensitivity or 100% sensitivity compared to PCR, but we have to remember that PCR is not 100% either. And I'm going to go through some of the differences as well of when this would be good to be used and when PCR is going to be good to be used. When you look at these tests and you read about them, they do say that they should be used for symptomatic patients. And I'll go through that when we talk about when they're best to be picked up, because although it says that, they are actually pretty good about picking up virus at the beginning in that pre-symptomatic stage. Now, with this, we have the ability to do a retest. These are inexpensive, quick tests. You can do multiple people, just do swab, 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 test, 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 test. Very easy to do large numbers of employees at a time. If you have a negative test and you're expecting it to be positive, or you have a positive test and you're thinking, how could this person be positive? They've been here, nobody else is positive, there's been no exposure, what we call pre-test probability, which is, what is your guess about whether they're going to be negative or positive? What is the likelihood that that person is positive or negative? So let's just say, this is an individual who has had no known exposures, no symptoms at all, and you get a positive test back. We may think, is this a false positive, or is this a real positive in a pre-symptomatic or asymptomatic person? We have the ability with this to just simply do another test. And when we do that, the two tests together increase the accuracy of the tests. And so I think it's the next slide that I'm going to show you, because I do want to talk a little bit about that. Actually, maybe it's a couple slides down, when we look at the time frame of doing it. So doing a second test, because it's so inexpensive and so fast, is a very easy thing to do. And it's part of the process and the protocol when it comes to antigen testing. So when we look at sensitivities and specificities, we shouldn't only look at one test, because if you said to me, I just want to test everybody in my workplace once, I wouldn't necessarily suggest that you do antigen testing. It's not a bad test, don't get me wrong, it's a great test, but it should be part of a whole protocol. The accuracy of it will increase the more frequently you are doing the testing, and when you have the ability to retest if you need to, if the result is not really jiving with what you think it should be, the pre-test probability there. So, as I said, pre-test probability is, do we expect them to be positive? Do they have symptoms and we're thinking they're positive? What is our community spread? If you have high community spread, then certainly your pretest probability is going to be higher than if you are in a community where there's really very low community spread. So these are all things to be taken into consideration when we're interpreting the results. And again, using that to guide whether you do another test. So it's a testing protocol that I was talking about here. So I'm just going to go to the tests that are approved right now. This is as of this morning. So there are 2 tests that are approved right now, just so that you know. There are another 5 that are under review, not yet approved, but Health Canada is looking into them. Sometimes there's a delay if somebody puts an application in for review to try to get approved until it's put out on the website. So there could be more, but this is what it is listed as of today. Okay, and CRISPR. All right, so what is CRISPR? So CRISPR is, and I think we're going to see more of this, which is really why I wanted to bring this up. Clustered, regularly interspaced, short palindromic repeats, CRISPR. That's the acronym for it. Essentially, it looks for genetic material or genetic sequence of the virus. And again, swabs from the upper respiratory tract that are used, so that's no different. It's qualitative, just like all the other tests that we have. But the nice thing of it compared to PCR testing is that it takes 1 hour to do in the lab. So from a lab, right now they're all lab-based tests. There will likely be point of care CRISPR tests, but there's none that I can find right now available that I've seen in the US or in Canada, but potentially out there. We don't have any approved right now in Canada, but from a speeding up the lab process, being able to process more results, et cetera, this is sort of, I think, where we're going. It's exceptionally accurate from a sensitivity and specificity perspective. They do say 100%. The studies that I looked at were samples that were contrived. So we know they're negative, we know they're positive, and is it picking it up, as opposed to a human swab, where part of the issue is, did we get enough virus on the swab? But from a comparison to PCR, excellent, excellent, excellent. It's a great test and it's fast. So I think we're going to see more of this. And so I wanted to bring it up. So when I talked before about the fact that we need to consider where the person is at in the testing, I wanted to show you this. So in those first 2 days after a person is exposed in the latency period, there is no test that's going to pick it up because the viral load is too low. There's virus there, it's replicating in our body, but there's just not enough there to spread to others yet, or to be picked up on a test. So then we have our pre-symptomatic. And what we know from looking at the studies is that antigen testing is actually very good and best when those viral loads are really high, when there's a lot of virus there in those couple days before you have symptoms and for the first couple days of symptoms. So again, this is looking at the average person where on day 5 they start to have symptoms. And you can see in the first, like in those 2 days before symptoms and 3 days afterwards, that's where antigen testing is excellent at picking it up. Now, PCR testing, on the other hand, which is great, is much better when we look at 2 days after you have symptoms, up to 7 days after you have symptoms. So when you have a person at, let's say, your workplace, and they come in and they just say, you know, I just started to feel sick on the way to work today, and these are the symptoms I have, et cetera. You know, you may do a PCR test and it may be negative because it may be too early to pick it up. Now, again, there are lots of things that we need to take into consideration. It's not quite that easy with PCR testing. It depends on the assay that we're using, the type of PCR test, how well it can pick up different levels of virus, like how many times it needs to replicate or amplify in order to see it on that test. And so there are different things to take into consideration. This is just a generality. So for example, if you did an antigen test on that very first day and it was positive and the person had symptoms, okay, even if you did a PCR test that was negative, I would still say to you, you know what, I'm thinking this very well could be. You need to go home. You need to be in quarantine. We can always do a PCR test a couple days later and see if that's also positive to confirm. But symptoms in an antigen test, pretty good, especially if there's been, you know, an understanding as to where that person may have picked it up from. If that same day, though, you have an antigen positive and a PCR negative, that even though PCR, we know from a sensitivity specificity perspective, may be a little bit better, again, it's the time frame that we're looking at. So we need to put all of that into consideration. Same thing as if a person comes to work and says, you know what, like maybe they were off work for 4 or 5 days and they said, you know what, I was sick for a bunch of days, I'm feeling better now, but maybe I had COVID, I don't know, and I don't want to spread it to anyone. You know, you could do an antigen test at that point that's going to be negative because it's too far after when they had their symptoms for it to show positive. And for that person, a PCR test would be much better. nucleic acid testing. And so it's taking everything into consideration. And this is what I was saying, that we cannot just rely on one test for each person and each, you know, situation in a workplace. We need to kind of put it all together for that. Again, the asymptomatic people from a time frame perspective are going to be picked up at different time frames as well by the different tests. So specimen collection, I just want to spend a few moments because I did talk about the fact that the how well our test does is very dependent on the swabs that we're getting, meaning how well it was collected, the type of collection that was done, and whether or not we picked up virus. So this is from Public Health Agency of Canada. And actually then there was a link, I think, to Ontario, Public Health of Ontario, actually, which is where this is from. And you can see that still, by far, nasopharyngeal swabs are the preferred kind of gold standard from a specimen collection perspective. However, we do know that you need a trained person to be able to do it. It is very uncomfortable. And, you know, it certainly is not a preferred way of testing if you are testing multiple times per week. So some people can do nasopharyngeal testing 2 or 3 days a week, but I think that employees would have a bit of a hard time with that. And so, you know, then we go down to some of the other tests, and then they talk about here how they are and what they are and when they're preferred and when they're not, etc. We know that if we take samples that are not nasopharyngeal and we take it from multiple sites, both sides of the nose and the throat, for example, that our likelihood of picking up the virus is far superior than just doing one of those alone. So there's been a lot of talk lately as well of saliva testing. That swish and gargle, I think it was actually out of BC that they had started talking about doing that. And these tests are great when we're doing multiple tests, perhaps, again, and, you know, for those that just can't tolerate the swabs. Right now, the tests that are Health Canada approved are not validated for oral fluid testing or for saliva testing or the swish and gargle. So it is something that I think will be coming. Now, in the US, I have a son who's at school in the States, and what I will tell you, there's a very, very, very strict testing protocol that they have where he can be tested anywhere from 1 to 3 times per week. And they are doing oral fluid swab testing. Now, again, the sensitivity of it is not going to be as high when we do that test. But if you're getting tested 3 times a week, if you miss it one of the times, you're going to pick it up the other times. And so I think we're going to see more of that when it comes to testing from a workplace perspective, when we're looking at a protocol. But as of right now, I'm not sure that, you know, I'm not sure whether or not any of the ones that I've seen that are Health Canada approved are can use the oral fluid right yet. They're not validated for that. That's not to say it's not going to be. So as I said, I think this is probably where we're going. It's not going to be for every test. So in a person who has symptoms, you really want to get a good swab, and you want to really make sure that you are getting the best chance of ensuring that they do or do not have the virus. But from a screening perspective, when you're not expecting very many people to be positive, when the community spread is low, when you're doing multiple testing, then that is where that oral fluid saliva testing comes into play here. I'm just going to mention pooled testing for a moment, just so that you know what it is. Pooled testing is when we take a number of tests. Traditionally, this is like we would use this for PCR testing. So we know that PCR testing is expensive. So pooled testing would mean we take a group of tests, you take a little bit out of each one of them and test it as a whole. Again, if there's not a lot of community spread and the prevalence of the virus in your area is not very high, we're kind of expecting, and they don't have symptoms, we're expecting everybody to be negative when it's just a screening. So they would screen, and if it's all negative, it's negative. That means that everyone who was in that pool was negative. If that test comes back positive, that means that one of those people who are pooled together for the test has COVID-19, is positive. And so they then go back and test everybody in that pool. The good thing about it is that it reduces the cost significantly when our prevalence rate, when the number of people who have the virus is low. You know, if we were in a situation where you know, many people are testing positive, then, you know, it's the likelihood of having to then go back and retest everybody's very high, right? So you have to look at, it's sort of a mathematical equation to look at the number of tests that you're doing together, the prevalence in your area where they are, the likelihood, the pretest probability that one of those individuals has it or doesn't have the test. And so you put all that together, but I just wanted to bring it up in case you hear about pool testing, that you know what that is. So in a world where we can have everything we want to from a testing perspective in the workplace, what do we really want? So, you know, in an ideal world, we want something that is reliable, that's fast, that's not expensive, that where you get the results right away. As I said, lab testing in Canada is good. You know, I would have said before it was great because we had turnaround times that were very quick within 24 hours, but in the last little while, and depending on the province that you're in, the turnaround time, you know, has been days or days and days. And that means, you know, if this is one of your employees, that's a person who is now off work in quarantine for that period of time until they get their result back. And when that is 10 days or 8 days or 14 days in some cases, you know, they've already done their quarantine, they're fine, and now they can come back to work before they even have their result back in some cases. So it's not very helpful from a contact tracing perspective if that person continues to be in the community. Now, hopefully, if you were doing workplace testing and waiting on a test, that person wouldn't be in the workplace working until you know their test. That's the recommendation, sort of really as a whole. If you're having a test done, wait at home until you get your result, just in case, to decrease that transmission to other people. But, you know, if we have the ability to have this inexpensive test where we can rapidly test everybody and get results that were pretty good from an accuracy perspective, then that's really where we want to go. As I said before, I don't think that antibody testing to date, with the information that we have right now, is very useful in the workplace, but we may learn more information and we may be able to put it together with some other kind of testing to be able to see. And maybe as we have more and more individuals and population who have been exposed, maybe this is something that will become useful. I would say today, I wouldn't recommend going out and having everybody in your workplace have an antibody test. I'm not sure the utility of that right now with what we know, but nonetheless, potential. The point of care PCR tests are great. Again, you have your result within hours. It's done at your site or somewhere near, you know, but again, there are some limitations, just more with the number of tests you can process in a day, because you have to keep sort of running it, and how many they can process on each machine. They can be costly, but certainly from a speed, accuracy, they're great. There's no issue with that, with these tests at all. And so, you know, it really brings us to antigen testing right now. Antigen testing is reliable, it's fast, it's inexpensive. And so if you're, again, just doing one test on everybody once, sensitivity, specificity, again, depends on where we're at within their test and what the population is, et cetera, with respect to false positives. And but when you put this as part of a protocol, and so the recommendation as part of a protocol would be to do antigen testing 2 to 3 times per week. So let's say Monday, Wednesday, Friday. If you decided that you don't want to do it 3 times a week, you want to do it twice a week, then Monday, Thursday. That's sort of where we're at. Again, this is something that you would just do regularly and have people tested on a regular basis, so that you know that you're going to be catching them depending on where they're at. If they're in the latency phase on the first test on Monday, by the time we get to Wednesday or even Thursday, they're going to be in that pre-symptomatic one. The goal of testing from the workplace perspective is really to prevent this tremendous spread that completely knocks out your workforce. And so, you know, doing one test a month or every 6 months is not going to be all that useful if that is your goal. But, you know, so you want to put this all together and find out what makes sense. There are companies that use both the point of care PCR and antigen, depending on the situation. They may use one or the other. So perhaps if the person is symptomatic or had been symptomatic, and they're not sure if they should return to work yet or not. We don't know that they had COVID or they didn't have COVID. Maybe a PCR test would be good at that point. So there's different utilities and different times and different places. So, you know, what I really want you to take from all of this is that there's a ton of information that you all need to put together to be able to figure out which test to use in your workplace at which time, based on, you know, where you're at and where your community is at and where your workforce is at with respect to the prevalence of the disease, et cetera. So things change as prevalences go up or down, and how effective one is, and rates of false positive. You know, if the rate of false positive is much, much higher than the actual community likelihood that you're going to get it, you're going to have more false positives than true positives, because in that community, there's not very many cases. And so you have to take all of that into consideration when you're interpreting the test and understanding what test to do and what the result of the test actually means. So that was a lot of information to go through. I hope that I did not leave you with more questions than you had before, but certainly if you do, I think we can go on to questions. We have lots of time, so I'm hoping that you all have tons of questions that I hopefully can answer for you. Okay, so I will unshare my, hold on, whoops, stop sharing my screen. There we go. Okay, great.
Yeah, thanks, Melissa. Lots to take in, and I appreciate you being so thorough that you're looking at the data as of this morning.
Yes.
So we'll go through some questions here. So so start with the first one. These are in no particular order. So do you know what the long-term effects are of COVID? And then specifically, have you heard anything about previous COVID positive patients having migraines?
Interesting. So, you know, there is a lot of data on post-COVID symptoms, and they range from neurological symptoms, you know, that may include migraines. I don't know specifically. I don't want to say that I've read a particular article that speaks to an increased rate of migraines, but there are certainly, and actually, I think, Jonathan, you went over this yesterday, some of the cardiac issues that people have afterwards, and certainly neurological. So it is not out of the realm of possibility that after a person has the virus, recovers from the virus, that they continue to have significant symptoms. So a lot of what we hear is a bit of a fogginess, or a like a brain fog, or a, you know, memory sort of types of issues, or just not functioning at the level that they felt that they were, and that can last for a long time. So you know, could that spark migraines in an individual? You know, when we look at the pathophysiology and why this is happening, and we don't have all the answers, I would say yes. I just haven't read anything specific to that. I don't know, Jonathan, if you have more insight on that to add.
I don't have any more insight, but I think that despite this feeling like a very, very long time that we've been living with COVID, it hasn't really been that long, and so we don't have all the answers. Most of this is coming out in due time. The more studies we have, the more data that we have on short-term and long-term disability, I think it's going to reveal itself much later on. So it's not out of the realm of possibilities that migraines or you know, chronic headache might be one part of a constellation of symptoms that we see in a prolonged fashion.
Good. Okay, thank you. So I'm going to take that question a little bit further, because again, it's so early on with COVID. We're still learning things daily. And when we talk about long-term effects, my mind goes to chickenpox, right? So you can have chickenpox was as grade 1. And then, you know, when I become 50 years old, I might end up with shingles. So how long do you think we literally are going to have to wait 30, 40 years to see if, you know, something like a shingles comes out of it? I'm not saying it's shingles specifically, but any long-term effects, like from the medical perspective, like how long do we have to wait to understand long-term effects? Just to touch on that.
So, you know, you're right, Jeremy. I think that we are going to learn things years and years and years and years down the road that we don't know now, because we don't know about long-term effects because it hasn't been that long. like real long-term chronic effects and whether it can. There are lots of viruses that either stay dormant or that the effects will last for, years and years and years and years later. So my expectation, just really reading into this virus and how complicated it is and how many parts of our body it can impact, that I'm expecting that, or would not be surprised, maybe I'm not expecting, I would really not be surprised if in 10, 20, or 30 years from now, we see ramifications or other diseases or illnesses that are increasing or cropping up that we can then maybe put together. We can't always put it together with the virus, but maybe put it together, linking it back to the SARS-CoV-2 virus and infectivity with that. Now, the other thing we have to remember to complicate all of this is that there are asymptomatic people who never develop symptoms, don't get tested, don't know they had it, and may develop symptoms later on, whether it's weeks later, months later, and potentially years or decades later, that they may say, well, did you ever have a COVID-19 infection? No, I actually got lucky, I never had it, but maybe they actually did. So it's going to complicate things for us in the years to come, and I don't think an answer will come so easily because of all of those factors.
So what you're saying, in 2070, we'll be back here and we'll dive deeper 50 years later.
Exactly. We may have a little more information then, yeah. I mean, this is literally the amount of the studies, the research, the papers that, that are coming out on a day-to-day basis is phenomenal. Like it's hard to keep up with all of it. And for a person that likes to read all that, and I do, it's sort of what drew me to all this. I love going through, the literature and what's out there. It's too much to keep up with. So because there's just a plethora of all this information, but it's great because as a world, we are all affected. And so we have the ability to learn on a much steeper curve than for a virus that only affected a few places in the world. So from that perspective, there's the advantage of us gaining knowledge at an exponential rate.
Okay, thank you. Next question. What should be done if you have an employee that says, I refuse to be tested?
That's a good question. I may have to turn that one over to Jonathan. So, it's hard because we are balancing here someone's personal right, but you're also balancing health and safety in your own workplace. So, at the end of the day, if you are doing testing in your workplace, it is to try to prevent an outbreak that will not only impact that person potentially and other people, but the entire workforce, the ability to continue to work. So I'm going to pass that to Jonathan, who may have more insights to that. Is that okay? I'm sorry I keep passing these to you, but
yeah,
I know you've been asked that question.
This is not a doctor's answer. This is a lawyer's answer. I do know that we've got a couple of lawyers who are on this webinar. Maybe they could sort of chime in to answer that question. I think that you really have to look at this even from our past experience with respect to flu shots in hospitals. Not everyone complies with that. We have nurses that perhaps choose not to do that. And there's some real hard, difficult decisions to navigate whether or not a person can come to work without necessarily being tested or without showing proof of immunity or whatever the case may be. I think this really falls into a legal realm that I don't know much about and I can't really comment on, and I don't want to lead anyone astray. So I'll appeal to the lawyers who may be on, maybe chime in and offer us some of your insight. That'd be great.
Perfect, thank you. Yeah. Okay, next question. So this might be more from the legal perspective as well, but what are some of the privacy issues associated with testing?
Yeah, question for the lawyer as well. But I mean, I think we can think through some of the considerations that we need to think through. And that may just be, maybe there are many people that have a fear of medical, what they call procedures, and, a swab, maybe too invasive for them, that the thought of doing that maybe causes anxiety or panic, et cetera. So there's that consideration. There's the consideration for the implications for their family with a test or not, so there's lots of different issues that come up when it comes to workplace testing. But again, that probably is best for, clearly we needed a lawyer here. That's best for a lawyer to answer. I don't know, Jonathan, if you have anything more to add to that, but that would be my.
Yeah, you know, a lot of this is driven by consent, and even if you insulate the employer from knowing the actual test result, you know, this is a binary decision. You're either cleared to go into work or not cleared to go into work. And so you may not be telling your employer what your test result is, but guess what? They can figure this stuff out. So I think all the provisions to insulate that should be taken into account. So if you are an employer and you're doing your own testing of your own employees, you'd be wise to have perhaps your occupational health department whose members are usually governed by, you know, colleges of physicians and surgeons or nurses, and they have a duty to protect that information in a confidential manner. They could tell the employer this person is not fit for work or this person is fit for work, and you get around that. But like I said, this is a positive negative test, so you know you got a not fit for work. Your employer's gonna know. There might be some provisions in there as an employer to say this is a condition of employment, this is a public health initiative, this is directed by somebody bigger than the company itself. So, you know, again, I'll defer this to the experts who are lawyers who can answer this more fulsomely. But I think those are the things that you need to be thinking about. If you hire a third party, if you get DriverCheck to do testing on behalf of your company, for example, we do that. We try to insulate and protect the personal and confidential information. This is all done through consent, so people need to actually consent to be able to be tested. By putting in those measures, we may be able to mitigate some of the privacy concerns, but I don't know if we'll get around it completely.
So can I take that a step further? And I won't be as eloquent as both of you guys can in answering this question, so that's why I'm asking it. So I'm Jeremy, I work at ABC Company. I've had a positive test for COVID. Now, if I've been going in and out of my office for X amount of days, will public health not notify through contact tracing me as an individual that, yes, Jeremy, you have had a positive test result? Wouldn't public health be notifying company ABC to say, and again, I don't know if they're saying it's Jeremy specifically, or if they're saying one of your employees has been had a positive test result. So can you just touch on that a little bit?
Jonathan, do you want to take that, or do you want me to?
Yeah, sure. Yeah, public health has a duty to protect individuals' private and confidential information as much as possible. So, and it's particularly the purview of public health to do contact tracing, although employers have taken that on themselves to some degree. Public health will get in touch with individuals who've been positive, and they will get details of where they work and perhaps who they might have been in contact with and where they have been walking around or sitting at a desk at the workplace. And when public health does get in touch with the employer, they will say, you know, an employee of yours has been tested positive. Here are the individuals that they've identified that they may have had contact with, and here are the locations that they've told us that they were. So they will try to sanitize that information and keep that protected to the extent that they can. I'm not sure if they're able to or should be disclosing individuals' identities. I think to the extent that we all need to, we all need to keep that information private and confidential. So that's what I understand public health to do. I don't know if that's actually their practice. When we were in touch with them, talking about contact tracing, as it applies to DriverCheck as well, we have employees who we need to be concerned about. But when public health is notifying employers, that's what they're telling us, that they are protecting the confidential and private information and just disclosing the information that is required to mitigate the transmission risk.
And I just want to add one more thing and just to be very clear that, you know, even if you're doing your own testing, if DriverCheck's doing the testing for you, wherever it may be, all positive results are reported to public health. So, you know, even if you decide you're going to do your own testing, you know, those positive tests must be reported to public health. So that is sort of something that needs to be put in place. And just to be clear, that has to happen regardless of whether you're doing your own testing or somebody's doing it for you. But that does happen, just to take that step back a little bit there.
Okay, thank you. So this kind of leads into the next question very nicely. So there was recent news in the Toronto area where there was a strip club that had resulted in something, I can't remember if it was 50 or 500, but it was a large number of people had tested positive as a result. And a lot of the people there were lying with their contact tracing. So they probably don't want their significant other, spouse, loved ones to know, hey, I was at a strip club and I happened to catch COVID. So the question here is, what if someone doesn't want to participate in contact tracing because it's going to reveal something to their loved ones that they don't want their loved ones or coworkers to know?
You look at it, it certainly raises, that's part of some of the privacy concerns that we were talking about before. It certainly raises some issues for some people depending on where you were and who you were with. So we can all think of many times where there are certain situations and people that would not want their family or loved ones to know where they were and who they were with, or the fact that they were in, even maybe they were a contact of somebody, maybe they didn't test positive, but they were contacted and contacted. But, again, public health acts in the interests of all of us as a community, while protecting the rights. So they can only deal with the information that that person is willing to give to them. They can't force information out of them. I don't know how anybody would be able to do that. But the mandate is really as a protection of the community, and to prevent spread. And so, doing that in the best way to be able to protect the privacy of the person is really their mandate. But again, I'm not sure how they approach it when a person says, I'm not giving you any information. So, but these are the things that that need to be taken into consideration. This is why it's not so easy. The contact tracing app that, we've all been asked to put on our phones is great because it's sort of this anonymous, if you were to get a notification that you were in contact, you would have no idea, who that was, or, and it's a little bit more anonymized that way. So really difficult to trace back. But in the reality of the world, you're right. When an employer gets called and says, Joe, Mary, Dan have all been exposed, sometimes you can put it together and figure out who the person was that exposed them. So it's just the way that it is, but raises concerns for some people.
So I think what we found out today is that we definitely need to have a lawyer on a separate webinar in the future to address some of these questions. Because to me, like, if you're flat out lying and it comes out, is there going to be any legal action taken against that individual? Because if I'm lying to protect my loved ones, but what about all the other people that I'm infecting? And if I become that super spreader, right? So, okay, so everyone who's watching today, look for that future webinar. No dates announced yet. Okay, next question. If you guys don't mind to address this, there's two more. That's okay?
Sure, of course.
Okay, so with all these testing options available and knowing way more than we did initially with COVID, why is it that we're seeing a resurgence or the second wave that seems to be so much more worse than what it was, say, early on?
Right. So I'm going to take a stab at that because there's a number of different reasons for that go beyond testing. So in the summer, depending on the province that you were in, some provinces had testing for anyone. You want to get tested, you go stand in line and get tested, and you don't have to have any reason to get tested. Other provinces were a bit more tight, saying, well, you can't get tested unless you have symptoms or you're a direct contact, et cetera. So every province was a little bit different. But nonetheless, we were doing a good amount of testing with low rates, but it was the summer and people were outdoors. And we do know that there is a very big difference with spread of the virus outdoors compared to indoors. So as the weather is turning, as university students are going back to school, as people are getting tired of isolation and not going out and doing things, there have been more gatherings, and maybe those gatherings have been indoor where there's more likelihood of spread, and maybe larger than they were supposed to be, whether it's university students, young adults, et cetera, even older adults kind of getting to the point of exhaustion from not socially, not being able to be in social situations. And I think all of those factors put together meant that we maybe let our guard down a little bit. Our numbers were not so bad in the summer. We were doing really well. And when we are not vigilant and we are not sticking to the 2 meters, wearing face protection coverings, washing our hands, sanitizing, that's when things tend to spread. So we know that indoors, it's going to spread faster than outdoors. And a lot of the spread, when we look at the numbers, and again, different provinces are different, but I'm going to speak to Ontario, where I am and where I know, is that a vast majority of our positive results are in younger people. And why is that? I don't even truthfully know that it has anything to do with the schools. It's university students gathering, it's young adults gathering, it's people who've been at some of these clubs and bars that were open, restaurants, etc. So we have to dive into it a little bit deeper, but I don't think it has to do with testing per se. I think it has to do with practices of people and maybe letting our guards down a bit and going indoors.
Okay. Jonathan, do you want to add to that?
Yeah, to be fair, I do think that it's all of what you've said, Melissa, but there's also some component of testing as well. When, and we're in Ontario, so we're a bit Ontario-centric with this, but in the summertime, we were having a real hard time getting a lot of people tested. So despite the effort there, we were testing, at one point I remember it was about 5,000 tests per day. And just last week, the Ontario government sort of paraded around their numbers, which was over 40,000 tests per day. So we're seeing a significant number of people, more people getting tested. And so, the slide that you put up on the positivity, so the number of positive tests compared to the actual number of tests, I think that's a really good metric to look at, and that is going up. So there is all this other stuff that's happening in, backyards and perhaps gatherings that we don't want. But the fact of the matter is that, we're not seeing, although we're seeing cases go up and the positivity rate go up, we're not actually seeing, not yet anyway, we're not seeing that translate to the same degree of hospitalizations or ICU treatments. And so I think we're actually doing a pretty good job. We're still doing a pretty good job. We could be doing better with actually keeping our masks on, keeping our distances, and going from there. But there is this component of, we can't say that the increase in case numbers isn't due to the increased number of tests that we're doing. I think that is a factor. I think the analysis is going to work itself out probably in a couple of months from now, by the end of the year, so we'll know and we'll see how things are. I'm really buoyed up by the notion that we haven't seen an equivalent increase in hospitalizations, or we were admitting over 1,000 people, a day at one point in the late spring, and we're not seeing that anymore. We had countless numbers of people admitted in the ICUs, and we're not seeing that anymore. So I do think that that's a large component, but this is all going to come out in the wash, and we're guessing at this point.
Yeah. Just as a reminder, again, if we go back to that slide that I showed, in the summer, we were less than 1% positivity rate for a period of time across Canada. We're now just about 2%. So there are more cases. I mean, even though we're doing more testing, when we look at the positivity rate, that gives us, again, we don't want to look at those raw numbers. We want to know what it really means. And so even when we are just looking at that, we are seeing that spike up. So I totally agree with you that it is because of the number of tests where our numbers are going up, but even our positivity rate is going up, which may continue as we head indoors. I heard there was snow in Calgary the other day, so I don't know how much longer the rest of us are going to be outdoors as much as we want to be, but it's just about balancing all of everything we need to be doing.
Okay, getting to the last question, Jonathan started to touch on it there when you were talking about the lab volume of testing. So the question says, we know there's public and private testing available. How is Canada coping as a country with the increased demand in with their lab capacity?
Well, you just have to look at the news to know that we are absolutely having issues when it comes to capacity. So, in Ontario, we were doing pretty well with capacity, and we were testing, and the numbers, as the numbers went up, the labs were having a bit of a harder time keeping up. There's been talk about sending tests to the US and trying to get rid of some of that backlog of tests that remains there and the longer turnaround times. But I do, my feeling is that this is something that, whether it's provincial or federally, they are absolutely aware of. I think they understand the necessity and the need to continue testing and the importance of that when it comes to preventing large spreads, as well as the need for quick turnaround times from a contact tracing perspective. So, my feeling on this, and sort of from what I've read and seen, is that, yeah, this is an issue, since all of this came up, there has been, at first they were saying in the news, even when I gave a talk a couple of weeks ago, there was everything in the news that says antigen tests aren't where they need to be. We are not going to be authorizing any of these to be used in Canada. And that quickly changed. And I actually believe that it changed not because all of a sudden they became all that much better, but there was an understanding that there is a utility and a way to use these in a world where we can't get testing for everybody who needs it, and where we're changing it province to province to now say, you can only be tested if you have symptoms or you're a direct contact. So I do believe that from a government perspective and all of the people who are leading all of this, that they're aware of it, and they are trying to make changes to increase the capacity of testing to be able to help us, especially get going into the winter months. I don't know if you have a different perspective, Jonathan.
No, I think just iterating what you're saying, I think one of the reasons that, well, a couple of reasons that the government pulled back on having everyone tested. And certainly one was a lab capacity issue. We just didn't have enough capacity for everyone to be tested. And then from an epidemiological perspective, and you talked about pretest likelihoods. If you have a low pretest likelihood and you have an asymptomatic person, it doesn't really make a whole lot of sense getting them tested, just because tests are imperfect and you might get bad results. But more importantly, you're just taking up another spot in valuable lab capacity analyzers. So I think a lot of that really comes to bear. Capacity goes beyond just labs as well. So we're talking about antigens, and this seems to be like the right thing to do for us right now. But I think one of the challenges that we're all going to be facing, even as an employer, if you want to have your employees tested, is just access to the antigen. They're just not available. The governments have bought them up, and so you're not going to have access to them. So you don't have access to lab capacity. You don't have access to antigen capacity. Maybe the trick is finding that mini lab, and maybe that sort of the interim measure. So I think capacity is a big issue across the board, across the country. It certainly seems to be that way, and it's going to be even more so for employers who are thinking about doing this for their own employees.
Very good.
Oh, by the way, just one bit of, there's been a number of questions about private versus public testing. The labs are earmarked. They have rights of first refusal. The government does for all of public testing. So even if you're doing private testing, that takes it takes a back seat. The labs are responsible for getting all the public testing first and foremost, which is the right thing to do.
Okay, and thank you for clarifying that, John, because that is the question I frequently hear too, is like public's always going to take a priority over private testing. Yeah. So there is that comfort knowing. Yeah, and I think it is the right move too from the government standpoint, absolutely. So that's all the questions for today. I'm sure people will be sending us more as they think things through, but I want to thank Melissa so much for presenting today. You're always a phenomenal speaker with a lot of insight, and I want to thank Jonathan for participating and help supports, because Melissa and Jonathan have been so involved with all this behind the scenes since February, and just seeing the thoroughness and how it's evolved over the 9 months that it's been, or whatever it has been, but just knowing that things are constantly changing, but we have those experts that they're responsible for helping support the direction the driver checks taken, and our marketing and sales team and all these people with communication. So just want to thank Jonathan and Melissa so much for being here today and for helping provide that education. So now I'm going to put a pause there. We did go a little bit over, but we do have a special guest speaker today who's coming on at 2:15. Our very special guest star is Patrick Weaverman, who's from our software engineering team, and he's going to do a 30-minute Q&A session on DC Access. So for some of those of you who don't know what DC Access is, we recently launched a software tool to provide daily COVID assessments. We're going to pause here for a quick moment. We'll show a video, And when the camera comes back on, you'll see a different smiling face here. So thanks, Jonathan, Melissa, and you're in good hands with Patrick in a moment.
Thanks, guys.
Thanks.